A rigorous, reproducible system is essential for avoiding satisfaction search, stopping your review of the chest X-ray once you find an obvious abnormality and missing secondary findings. The universally accepted framework in clinical practice relies on a strict pre-read quality check followed by the ABCDEFGH sequence. Pre-read check. Before interpreting pathology, confirm the technical quality of the film. A poor quality image can easily mimic or mask disease. R for rotation. The thoracic spinous processes should align exactly midway between the medial ends of the clavicles. Rotation significantly alters the apparent heart size and lung density. I for inspiration. A good inspiratory effort brings the diaphragm down to the level of 5th or 6th anterior ribs or 8th or 10th posterior ribs. Poor inspiration mimics basal consolidation and artificially enlarges the cardiac silhouette. P for penetration, that is exposure. You should be able to faintly see the lower thoracic vertebral bodies through the cardiac shadow. Upper thoracic spines are clearly seen through the tracheal air column. Over-penetrated films black out subtle lung markings. Under-penetrated films obscure the lung bases and retrocardiac space. The ABCDEFGH sequence. A for airway. Trace the trachea down to the carina. It should be central or slightly displaced to the right by the aortic arch. Check for narrowing foreign bodies or deviation. Tracheal deviation suggests a mediastinal shift, often driven by tension pneumothorax, large effusion, or massive atelectasis. Ensure the mainstem bronchi branch at a normal angle, usually less than 90 degrees. B for bones and soft tissue. Scan the ribs, clavicles, scapulae, and the visible spine. Trace each rib individually from posterior to anterior to avoid missing subtle or hairline fractures. Look for lytic or sclerotic lesions or step-offs. In the soft tissues, check for subcutaneous emphysema, surgical clips, or abnormal masses. C for cardiac silhouette and mediastinum. Evaluate the heart size. On a PF film, the cardiothoracic ratio should be strictly less than 50%. Right heart border is formed by the right atrium. Left border is formed by the left ventricle lower and left atrial appendage at the top. Mediastinum. Check the aortic knob, the pulmonary bay, and the hilum. The left hilum normally sits slightly higher than the right. Widening of the mediastinum more than 8 cm is a red flag for aortic dissection or significant lymphadenopathy. D for diaphragm. The right hemidiaphragm is typically 1 to 3 cm higher than the left. Check the contour. It should be a smooth, continuous dome. Look closely for free air under the diaphragm, pneumoperitoneum, appearing as a thin radiolucent crescent, which requires immediate surgical attention. Inspect the lateral costophrenic and cardiophrenic angles. They should be sharply pointed. Blunting indicates pleural effusion or pleural thickening. Note that it typically takes 200 to 300 ml of fluid to blunt the angle on a PF film, whereas a lateral film can reveal as little as 50 ml. F. Fields. Lung fields. Divide the lungs into upper, mid, and lower zones. Compare left to right symmetrically, scanning in a zigzag pattern. Check for consolidation, masses, or solitary pulmonary nodules. Look for interstitial patterns such as reticular opacities or curly B lines at the bases. Follow the vascular markings all the way to the periphery. If they stop abruptly, look closely for a thin pleural line indicating a pneumothorax. In the setting of elevated left-sided filling pressures, look for cephalization of flow, dilatation of upper lobe vessels, also known as Andler's sign. G for gastric bubble. Locate the radiolucent gastric bubble under the left hemidiaphragm. Ensure it is in the correct anatomical position, absent or on the right side in situs inversus. Check the distance between the lung base and the bubble. Abnormal separation can suggest a subpulmonic effusion or gastric wall pathology. This chest X-ray shows the fundal gas bubble. In addition, the structures marked are the right atrial border, RA, RPA is right pulmonary artery, SVC, superior vena cava, aortic knuckle, main pulmonary artery segment, left pulmonary artery, and left atrial appendage region that will bulge out if the left atrial appendage is enlarged. H for hardware and tubes. Methodically identify all lines, tubes, devices, ensuring correct placement and integrity. Tubes and lines. Endotracheal tubes. Tip should be 3 to 5 cm above the carina. Central venous catheters. Tip at the cavo-atrial junction. And nasogastric tubes, tip below the diaphragm. Devices, pacemakers and ICDs. Check lead continuity, fractures and positioning, sternal wires and prosthetic heart valves. Upper panel illustrates the positions of tricuspid aortic pulmonary and mitral valve prosthetic valves. Lower part, an enlarged fluoroscopic screenshot of the sewing ring and struts of a caged ball prosthesis of the aortic valve. And middle you can see the mitral TTK Chitra prosthesis, which is seen as a ring within the cardiac silhouette. On the other side you have the pacemaker with the atrial electrodes, ventricular electrodes and sternal suture wires, because the patient would have had another surgery before that or after that.